CataractCoach.com, podcast series, episode number 45, with Lucio Buratto from Milano, Italy. 4 decades of cataract and refractive surgery expertise. Our podcast today is sponsored by Harrow Incorporated. Welcome to our Cataract Coach podcast. Today we have an amazing ophthalmologist who's been a pioneer in so much related to refractive surgery and cataract surgery. And that's Lucio Buratto. Lucio, welcome to our podcast. It's such a pleasure to have you here.
Thank you, Uday. Very nice to be here. With you. I really enjoy your products, your cataract coach, and your podcasts, and so on. In fact, I was a little bit waiting for an invitation. In fact, and finally I get it.
Well, I've been a big fan of yours because of your meeting, Video Cataracta Refractiva. Tell me about this meeting. How did you get the idea? You're the pioneer. You're the number one person who started this many, many years ago.
You know, during my beginning of my profession, I need to learn. And in 78, 79, I travel a lot. Travel a lot in USA. I went to Los Angeles. I went to Houston. I went to Philadelphia. I went to New York. I went everywhere. And frankly speaking, traveling was expensive, time-consuming, and a lot of loss of presence in the office. Mm-hmm. So one day I said to myself, why should I go around the world when I can invite the best surgeon to come in Milan and enjoy their surgery, and not only for me, but for other Italian colleagues. Right. So I asked to Cooper Vision. You remember the name of this company, Cooper Vision?
Yes, long ago.
And they supported the first meeting. We had 30, 40 people, not many, but we had a lot of success because at that time, nobody was showing the surgery. First of all, because the surgeons were very few, and they wanted to keep the ability to do surgery by themselves. They don't want to teach. They don't want to have people making surgery for instead of them. So when we started showing this live surgery cataract, everybody was crazy. Lucio is showing cataract surgery, not only showing, but he's also showing complications. That's right. That's the most difficult part of live surgery. So we started with the first meeting, and after 6 months later, I did a second one, and now we're still doing after 43 years. I mean,
wow. Yeah, I participated in your meeting. Must have been 15, 18 years ago in Milan to do a live surgery, which was a lot of fun. I think it's the best way to learn.
I believe that live surgery is one of the very, very best tools for teaching and learning. It's teaching because the participant can see really surgery. They can discuss about the surgeon. They can see how the instruments he used. They can see how he performed the different steps of the surgery. Especially they can see when there is a complication, how the surgeon solved the complication. And this is very, very important. I mean, absolutely important. And not only for the doctor. I mean, live surgery is absolutely very important also for the companies, because it's a wonderful system, a wonderful tool to show their technology, their instrument, their IOLs, their phacoemulsification machine, and so on. So it's for both of participants, the doctors and the company, is a super tool of learning and teaching and selling.
Absolutely. You were probably the first surgeon to understand that refractive surgery and cataract surgery should go hand in hand. They're the same.
In fact, as soon as we started refractive surgery, we started organizing a second meeting during the year. One was video cataracta, the other one was video refractiva. At that moment, the two surgeries were a little bit different, I would say. Not only a little bit, very different.
Sure.
Time consuming and spacing, I mean, the two surgeries combined, and finally now we have one single type of surgery, that is cataract surgery and refractive surgery, that is together. I mean, there is no any difference, I would say, because both of them are very, very refractive surgery.
For sure. Now, over the years, your meeting has evolved. At the very beginning, and 40 years ago, maybe there was radial keratotomy, then became PRK, then became LASIK, then for the IOL side, so many new innovations with IOLs. So
Yeah, absolutely.
what has been the journey? What has been the interesting parts for you?
In my opinion, the most important step when in '84 we did a satellite live surgery. We connected
Mm,
4 countries in Europe, and it was absolutely the first satellite live surgery meeting. And we spent a huge amount of money. I don't tell you the amount, but several $100,000 for that. I mean, and after we continued to do satellite meeting, and we did one day, in one event, we connected more than 20 countries, different countries with live
wow.
surgery with the satellite. But we had the opportunity to show every kind of surgery from, PRK, the very first PRK, for the very first intrastomach keratomyeliosis that I developed on 89. I, I was the first using the laser in the stroma for keratomyeliosis. At that time, it's a long story, but at that time we were performing keratomyeliosis with the Krumach device. And with this technique, we had to cut a lamella of 360 degrees with a thickness of 360 microns. And we used to cut the refractive part on the stroma side of the lamella. So when we had the laser, the sequence was why not to use the laser instead of a blade
Sure.
to do that. And we started using the laser in October 89. And 1 month later, we did the first also in situ ablation with the laser. And but still, I was performing the 360-degree cut. And a year later, Palikaris developed the LASIK, and that was a big advancement in refractive surgery. That is the very very LASIK procedure, I would say.
Sure. I mean, some of the important innovations were, like you said, initially 360 degrees. But
Yeah,
then we decided, okay, we'll leave a flap, we'll leave a connection, maybe
yeah.
do 300 degrees. When did that happen?
It was 1990, 90,
Wow.
between the 1991.
Wow. And then now, of course, that changes it forever because now you don't have to worry about flap orientation, displaced flaps. It's a lot more secure.
I remember when we started doing the laser intrastroma, we had a lot of visitors: Steve Brint, Steve Slade, we had Ron Stasiuk, we had Robert Maloney, many Americans, many international, many Australians also went to see the procedure because it was really an innovation, very important innovation. I mean, being able to use the laser. At that time, the only problem was that we were treating between 10 and 20 diopters of myopia with an
Wow.
optical zone of 4, 4.5,
Wow. Very
4.6.
small.
Very small optical zone, unbelievable. If you think today to an optical zone like that, you cannot believe that we did that.
And such high degrees of myopia, more than -10, -15.
More than that. I still have some patients coming because, it was a long time ago. That surgery 30 years ago. And some of the patients were 25, 30, and they're still alive. So I still see some of those patients. They're still happy, but they complain a lot about halos and the night vision. You can imagine that.
Of course, yeah, with a very
Of
small
course,
optical zone, 4.5 millimeter
yeah,
optical zone.
yeah,
At nighttime with
exactly,
larger pupils, they'll get more of that effect.
exactly.
And so when did you combine the cataract meeting, video catarata and video refractiva? When did you combine them?
It was around 97 or 98. After 6 or 7 years that I was performing refractive surgery with the laser and so on. In fact, I started the keratomyeliosis long time ago. I started in 85. I did my first
Wow.
keratomilesis in 85. I some I was hosted and I used the Baracare cryolate, but
Hmm.
I didn't like that really. It was a very amazing, very interesting, very fascinating technique, but too difficult. So when one day I was in France for a live surgery, I saw your crewmate performing a non-freezing keratomilesis, and understood that this was a procedure for me. So I bought the instrument and we started. First, we started with iBank. We spent several months experimenting with iBank the iBank in Mestre. And finally, when we were ready with the technology and the procedure itself, we started doing on live patients.
Well, the important thing is that you had to learn everything on your own because the way you were taught in 1970 something is not what you're doing today. So it seems like every few years you have to learn a new surgery, a new procedure, a new technology.
That's you are perfectly right. It was a long way, a long, procedure to learn everything. I started fake emulsification and I learned it myself. I mean, I had
Wow.
a technician bringing me animal eyes, explanted animal eyes, and for a month we did phaco on animal's eyes. And finally, I invited Ulrich Darden to assist me with the first few cases. And after I started alone, I mean, it was very, very successful. I mean, between 78 and 89, in those 12 years, I did a huge amount of cataract surgery because nobody was doing that, especially
Right.
nobody was implanting IOLs, posterior chamber IOLs. I had a chance to meet Steve Shering in Cannes on 78. That was the big meeting in Cannes. And Steve Shering presented for the first time his IOL. At the end of his talk, I ran to talk with him and said, please invite me to Las Vegas. I want to see you in surgery, really in surgery. And a few weeks later, I went to Las Vegas and I saw the patient, the post-operative result with the patient. The patient was very, very happy. So I went back and I started implanting the first sharing lenses.
But it was a lot of controversy at the time. There were some ophthalmologists who were saying, don't put a lens in the eye. It's like a ticking time bomb. So the standard at the time was they left the patients aphakic.
It was a difficult time. I mean, but it was very exciting also
Right.
because I had a lot of enthusiasm from the patients, and I had also had a lot of problems with the more traditional eye doctors in Italy because they didn't appreciate it very much that a young private doctor was importing a new extraordinary procedure, fake emulsification with the small incision. What is that small incision? And he's implanting a piece of plastic inside the eye. Horrible, horrible. But
Right.
I was tried. I decided to go, and I went through.
Well, history has proven you correct. History has shown us that, of course, we want an IOL in the eye. Of course. But at the time, it was not such a simple decision. So you had to import the lenses, the IOLs yourself?
No, no. Finally, we had a company in Milan who was importing the Cooper Vision and also the Iola. But I went to visit the factories in LA. I was
Yeah.
invited to see how they produce the lens and so on. I Yes, I had the support of a company, an Italian company for that. What I imported was the Elon because in '82 I went visiting somebody in the USA. I saw using this strange substance.
Viscoelastic, yes.
I went to the main nurse. I said, "Please, can you give me one of those?" So no, no, I cannot. So I went to the doctor saying, I would like to pay 2 syringes of that. Please give me. No, I cannot. The hospital is finally I obtained 2
Yeah.
syringes and I went back And frankly speaking, I had two serious complications because I didn't know at that time that we had to remove the elon from the eye. So I had pressure,
Oh,
I had corneal edema, and it was not the beginning of eye elon a good experience for me. But little by little, I understood how to use it, and it is very, very important substance that helps us really a lot during our surgery.
oh, for sure. I can't imagine doing intraocular surgery now or cataract surgery without using a viscoelastic.
We were implanted the IOL under air. It was a nice procedure. I still have many movies. I have a large collection of historical movies. I still have some videos of where I was doing cryo extraction.
Wow.
And I have videos implanting the sharing lens and the Kratz lens and the Siski lens and the Simcoe lens without a viscoelastic under air. And with a 6.5 incision, not
Sure.
just 2.5 or 3 millimeter incision. So it was quite tricky to maintain the anterior chamber with air and avoid damaging the corneal endothelium. Especially in this period, we didn't know nothing about endothelium. I mean, I bought the first, I will say, binocular or microscope that was showing the endothelium far away. And
Hmm.
it was around, I don't know, 81, 82. But later we started understanding the importance of endothelium during cataract surgery. And with the help of viscoelastic, we had much less corneal edema. Because at the beginning, I remember many of our patients had quite a
Correlated.
spectacular corneal edema.
Well, I mean, we should say back in the day that there was no phaco power modulation. So phaco was energy was on or off. You couldn't deliver it in titrated doses. Also, you're not protecting the endothelium. And then a lot of people at the time were advocating doing the phaco in the anterior chamber. And so a lot of patients developed
And
PBK, pseudophakic bullous keratopathy.
Yeah, and the most strange thing is the pipe we used for the phaco, because it was a silicone pipe, thick like that, and we used to sterilize it. We sterilized 5, 10, 20 times the
Right.
same pipe, So it was completely different process. I still have the machine. I mean, in my office, in the waiting room, I still have the very first phaco machine, the Cavitron Canon 800.
Wow.
8,000, 8,000,
Wow.
8,000.
Yeah, that's Cavatron, Kelvin 8000. Yeah, that's fantastic. So I think probably the big change came with then foldable lenses, because before this
Yeah.
you did phaco through a smaller incision, 3 or 4 millimeters, but then you had to open the incision to 6 or more millimeters to put the IOL because the IOL was rigid.
Yeah, the folding IOLs were very attractive. I mean, I really implanted the very first silicones, the very first hydrogel, etc. But I mean, I also designed many folders for silicone lenses, because
Right,
silicone was not easy to manage. They were opening inside the eye like an explosion.
right.
So it was. But they were very interesting because we had the ability to do surgery without surgery, and it was a big advancement. I mean, for the patient, for the surgery itself, and for the visual recovery, very short visual recovery.
So we certainly do a lot now, only foldable lenses, obviously, to keep incision small. There was a time, though, you remember, maybe 15 years ago, where people wanted to do bimanual phaco instead of
Mm.
coaxial. And the idea was you'd have two small incisions of maybe 1.5 millimeters. And they even had special thin IOLs that we could go through a
Yeah.
tiny incision. Why do you think that bimanual didn't take off? Why do you think we're back to coaxial?
I did some tenths or more cases with that technique, but I didn't really enjoy that. I'm able to use the two hands very easily. I mean, I'm not using only one hand during surgery. So for me, it was quite, simple to learn this procedure. But I did several cases, but I wasn't happy with the procedure. And the IOL, it was too small, also too soft. Alio was performing many of those cases. Professor Alio in Alicante. But I did enjoy that procedure, frankly speaking. I remained on the axis of similar lens. I was one of the very first user of axis. We implanted the first axis in Italy with at Video Cataract, and Steve Brint implanted that IOL.
Yeah.
And the second case, I did the second case after him.
That's fantastic. Yeah, you video cataract and refractiva, you've had a lot of firsts. First for the acrylic lens, like you're saying, the Acrosoft lens, but a lot of other things, you know.
I did a study, for example, for the FDA for the HydroView, and strangely, in my experience, the HydroView performed very well. And
Right.
once they were approved, the day after they retired, they removed from the market because they had several opacification. But it wasn't the lens itself the cause of opacification, but it was the use of other substances during surgery. In my experience, all the cases did very well. I was lucky,
Yeah,
I must say. I was lucky.
fantastic. What are the for your meeting now? Are you doing it about 50% refractive, 50% cataract? Do you do equal?
Oh, we changed by year and years. We changed the way to do the meeting. And this year we decided to change again. From this year, we wanted to do a very small meeting, a very particular meeting with one single topic, and like a club. I don't want to have any more 1,000 people. It's a lot of work. I mean, and the
Yeah.
company and this, and there are so many meetings in Europe, in Italy, and I want to differentiate a little bit and make an innovation also in meeting. I did many innovation in my experience in my surgical profession, and also I want to do on organizing a meeting.
Fantastic. So, yeah, obviously you'll continue the meeting. It's such a great meeting because it's a great learning platform. Are
Yeah.
you also going to have a separate or combined online presence too? Maybe have the meeting live
Yeah.
online?
Yeah, during the COVID, we did all the meeting only on live and online for during the 2 years of the COVID. Now, what we do the meeting in person, and we use the sessions of the Congress to do every week evening session, in which session we discuss the cases we presented at the Video Cataract for the doctors who didn't attend the meeting.
Mhm.
So we had a big meeting once a year, and every week or every 2 weeks, depending of the period of the year, we spend an hour in the evening, and we discuss with a panel the cases that we projected and we used during the meeting. And after that, we position everything in a video library we have. We have a very nice free video library that is occhio.eu, where we have thousands of videos, new and old, historical and very updated, several sessions of video cataract. And the idea is to increase the content of this, video library that is available for free. So especially for young doctors, can be very helpful. Let me say, one day you want to do a special case the day after. You don't know exactly how to do it. You can go on Occhio, you can see 3, 4, 5 surgeons performing the similar case in a different ways, and maybe you find the right way to do your case.
Well, it's amazing to be able to learn like that because if you look back, 1980s, 1990s, you didn't have that ability. It's only now that you can, like you said, you have a difficult case coming up tomorrow. Today, you can look online, learn from other
Yeah.
surgeons, and do a better job for your patient.
Today is much easier. I would say there is a lot of content. The number one in the world is your cataract coach. That is really a super project, super idea, and people can find everything there.
Sure.
But also from other surgeons, from other hospital, there are many videos available on YouTube and other channels. And for a doctor now, there are very few reasons, in fact, to travel around the world. if I remember so many trips I did, on my life, let me say, just for refractive surgery, 1 year I spent 3 months in US. I went to Philadelphia, I went to LA, I went to
Houston.
Houston, I went to New Orleans, I went back to Philadelphia, I went back to LA. The same trip, I visited 8 different surgeons, 8 different towns. I was traveling every day. Because now you open your computer and you watch everything. It's much easier. But
Yeah.
it's less fascinating, I would say. It was I really enjoy my experience, my life in surgery, in learning and teaching and doing surgery for my patient. I really like my profession. In my opinion, is the very best profession that you can have.
Yeah.
Really.
And I think we all feel that way. Every day I'm thankful that I'm an ophthalmologist. I'm just
Yeah,
feel
me too.
blessed.
Me too. Me too. I fully agree with you.
And
Really,
if,
when
if if you send me the links for your sites, I'll put it in the podcast and I'll put it on
yeah,
Cataract Coach. So any others, the young surgeons want to check out all his videos, we'll put all the links below. So you'll have that.
okay, I will. I
And
will.
then I also, like you, and love to travel. There's a lot of learning, of course, but you can learn arguably on your phone, on your computer. But I like the personal interaction.
Now I limited my traveling. I go to the ESRS, ISRS. I went to the SOE, to European. I have a couple of invitations by the Hungarian and other societies, but personal invitation to give a special talks. I'm 80 this year, so I still have energies. I still desire to travel, but you can learn everything. You can see everything now online. So there is less need really to spend time in traveling. Also because traveling is becoming more and more difficult. Apart from the cost, it's
Yes.
becoming difficult because Uh,
Yeah, it's a lot more difficult to travel. I still enjoy it, but there's a balance. There's certainly a balance there. Well, where do you think we're going to go with cataract and refractive surgery? If you
that's a
look,
nice
what do you think
question.
in the next 5 or 10 years? Where do you think we're going?
I think not now, not in a year or two, but the robotics is the
Robotics,
way. I think more and more now we are already performing a part of the robotic surgery in a cataract surgery. When we do, let me say, the femtosecond, I do femtosecond in all my cases. This is part of the robotic. And
sure.
after when you position your IOL, toric IOL with electronic device, that's robotic. And when you introduce an IOL with pressing a foot switch, there is a more robotic. But this is only the beginning. In my opinion, in about 10, 15 years, the improvement of software, the improvement of artificial intelligence, the improvement of, investment in robotics, we will arrive to a full cataract surgery done by a robotic.
I think you're right. I'm working with a company now that's doing robotic cataract surgery as a new project, and it's quite amazing. The
Uh,
progress is being
I,
made. Progress is being made very rapidly.
I fully agree on that. It takes some time because, but in Vienna, they showed several videos where, the surgeon is in another room, not in the surgical room, and in
Right.
front of a screen, managing different tools. And you see this little technical part moving and go inside the eye. It's very, very amazing, I may say.
It's going to be very amazing in the future. We're going to have incredible technologies. Now, what do you think about IOL side? Do you think we're going to have at some point a truly accommodating IOL?
I don't think so. We tried the very first commutative IOL, the American one, the German one, other companies also, but finally they don't accommodate. And now we use more and more the IOLs related to aberrations. And
Mhm.
frankly speaking, they do very well. is something that you don't have in the United States, and this is a pity. The only one available is the Vivity, but there are several others like the B&L, the BVI, there is the Rainer, there are other companies having very, very good lenses. They correct presbyopia, intermediate presbyopia very well, and the patient have very good quality of vision, much better than the multifocal that I was using. Uh, I know that I'm probably somebody say that I'm wrong, but I don't use anymore multifocal eye. Since the last 3 years, I use only these aberration related IOLs, and my patients are happy, and myself is happy, and we do more and more patients who just need correction of presbyopia. They don't have cataract, but they want to have the removal of near glasses, and we are able to do that. So the way is to develop this concept probably and obtain a better near vision. But the most important thing that we have to remember is that we need quality of vision. Quality
Right.
of vision is very important. If you have a vision for every distance, but you don't have quality of vision, patient is unhappy. If you
Yeah.
maybe you don't have the ability to read a smaller letters at 30 centimeters, but if you can see the computer without the glasses, the patient can be very happy, and if the quality of vision is good.
So the type of lens you're using now is like extended depth of focus, but based on
Yeah,
aberrations.
yeah, exactly,
And
exactly.
how much range do you get? One diopter, one and a half, two
They
diopters?
correct from 1 dioptria to 1.6.65 diopters of presbyopia. So that means that if you want to read without glasses, you need 1 dioptria, more or less. But if you do a slight monovision, you can reduce also the dependence from near vision also from those lenses.
So you'll do emetropia and maybe the other eye -1?
Minus 0.5, 0.75, not one. It depends. When we can, we try with the contact lens first. Let me say, we have a
Mm.
patient of 44. He wants to have correction of presbyopia. He has no cataract. We put contact lenses and we show him how can be the vision after surgery with a monovision, slight monovision, a little bit more monovision or higher monovision. And when we find that the patient happy, we do the surgery with this in mind.
Well, obviously the quality of vision must be great because you're operating on 44-year-old who's probably emetropic and presbyopic, so plano presbyope, and you're making him pseudophakic. So obviously the quality of vision has to be there. Because I know, for me, if I have a 44-year-old who's emetrope and presbyopic, I don't want to put a multifocal lens in.
Till 3 years ago, I presented many videos on how to explant a multifocal IOL. And I consider myself an expert in explanting multifocal IOLs.
Yeah, I
I
think
presented
yeah,
I
for most
presented
of us,
also the meeting in USA at where was that meeting? And in Boston or Houston, I don't remember. 2-3 years ago, the SLS.
yeah. But for most of us, I think a commonly explanted lens is a multifocal lens. Patients not happy with the quality of the vision.
I had a patient who had that lens since 8 years. And during 8 years, he went to visit, I would say, at least 15 different doctors, saying that he wanted to do something for his vision because he was completely unhappy. He was under psychotherapy and everything. So I was able to explain. You can do also after many, many years. You have to use a special technique. I mean, very soft and smooth and procedure, but you can remove the lens after many years also. And this was one of my first very happy patient, really happy patient when we implanted just 2 monofocal lenses. The
Hmm.
quality of vision was super, and still today, the lens that is giving the best quality of vision is the monofocal anyway.
Right, of course. I mean, we all have our preferences for obviously best image quality, and with a monofocal, it's even going to be better image quality than these aberration extended depth of focus lenses.
Mm. Yeah, but the monofocal has a lot of limits.
Yeah,
Nobody wants to have any more now, more or less. I mean, less and less.
right, Randall, for sure.
Let me
So,
go
so
back. I make a question to you. What is the
sure.
future of refractive surgery?
Well, I think we're going to change it so that young people who are now increasingly myopic, because the amount of time that young people spend on their mobile phones and
That's
computers,
terrible.
incidence of myopia is very high now among young people. So I think it'll be like getting your teeth fixed. In the US, very common when you're a teenager, you get the braces on your teeth, they get your teeth straight. I think when you turn about 20 years old, you'll have corneal refractive surgery, either LASIK, SMILE, something similar, and then that will carry you until you're 45, 50 years old. When you become presbyopic, then we'll do an IOL of some design or another, maybe like you're explaining, maybe hopefully accommodating lens, you never know. And then I think it's going to be something like an adjustability. So a lot of people have talked about refractive index shaping, so being able to change the IOL power even many years later, so that every 5, 10 years, as the patient develops more and you get older and get more against the rule sill, you can do a little bit more treatment on the IOL and maintain great vision throughout life. That's my hope.
In fact, I mean, the refractive surgery has a multi-choice, multi-techniques depending of the age and the evolution of life and the technique and science in developing new IOLs, new techniques, and so on. But the laser, I mean, it looks like being there for many years since now. I mean, it will stay for long. I think the laser. IOLs, phakic IOL are becoming more and more common, but
Right,
it's still intraocular surgery, so somebody is a little bit afraid about that. But anyway, the the problem is that more and more and more patients want to stay independent of glasses, and
right,
there is a good future, in my opinion, for refractive surgery, but we have to do good surgery. I mean, a good examination before surgery, good surgery with good technologies. We made the mistake 20 years ago, more or less, when we had a lot of TVU and newspaper articles against LASIK and PRK and so on, because many surgeons were not performing, the right procedure in the right patient and
right.
without doing good examination. Now we really need to be very serious if you want us to have a refractive surgery developing more and more.
Right. We have to be very careful to offer the right surgery to the right candidate.
Exactly, exactly. I agree.
And yeah, I think here in the US, when LASIK was first being approved, like around the late 1990s, early 2000s, I think too much LASIK was being done on people who weren't great candidates. So I think there was a little bit too aggressive.
If you consider that the first case like that it was done 34 years ago, I mean, is a long time. I mean,
Right.
so the technology improved a lot. I remember I had the first Summit laser. It was a boom, boom, boom.
Yeah.
It was delivering a bomb inside the eye, not on the surface of the eye. Now we have very soft, very controlled, very, very smooth, very, it's another life. It's another
Yeah. I
life.
mean, a lot of our listeners for this podcast are young ophthalmologists, 30s and 40s and 50-year-old. We have to remind them that there used to be a broad beam laser. So one single big beam that could be up to 6, 7, 8 millimeters diameter. And it was a very low repeat rate. So maybe 10 hertz, 20 hertz, 30 hertz. So ta 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 ta. And it was a very loud laser.
Mm. I still
Now
have
you're
some
used to,
movies.
yeah,
I still have some movies on that. When I watch it, I really is amazing.
right. Now we're used to these flying spot lasers with multiple spots, 400, 500 hertz, and it's just like a quiet.
very smooth opticals, very nice, and the quality of vision, especially, very good. I mean, very few patients complain. Only the high myopes, they complain about halos during night. Every technique you use, you can put an IOL or you can do a LASIK or a SMILE, whatever you want. When those patients have a high myopia and a large pupil, you might expect, visual problem during night. But I explained very carefully that to the patient, and I told them, be ready to receive that problem. Is the only one that you can get from the surgery, but it can be a problem. No one of my patients, and I think for you is the same, want to go back from their surgery after
Right.
explaining what you can do and what they can receive from the surgery also.
Well, I think you bring up an important point. Make sure you explain to the patient before surgery. If you're
Yeah.
a high myope, -8, -10 myope, and you have large pupils at night, you may have this nighttime glare inhaler. In fact, you probably will. But those patients would still rather have the laser done and no glasses, and even if they have halo at night, instead of going back to being -8 or -10.
See, the limit of the life surgery is the fear. Patients are afraid. They have
Yeah,
fear of having surgery because their eye is so, important, so
of course.
special, so, sensible, so everything.
So, Lucio, so you've had an amazing career. You started video cataract and refractiva when you were probably in your 30s, long ago.
I
You were a
I was
young surgeon.
I was 34.
Yeah, right. So, what have been the most amazing things? What have you learned along the way? You have an experience that very few have. You have so many decades of experience. You've done every type of surgery. You're self-taught for everything. What are kind of the important lessons? I think one of them we talked about was you have to keep learning because technology you will keep changing the way you do surgery.
First of all, let me say that I recorded all those surgery. I have in my library all the videos since 1800, since the first meeting. So I have 43 years of video of surgeons. I have all the surgeons from all around the world coming to the surgery. I had Dick Listron, our fine Steve Brint, Akaoshi, and everybody went to the surgery video cataract. And I still have those videos. And one day I want to publish those videos because they are very special. And staying with those surgeons, I learned a lot. I learned how to manage the patient, and then learn how to do the surgery, the little details of surgery, because is there. Our surgery is microsurgery. You don't learn big steps of surgery. You
Mhm.
learn from the smaller details, and I mean, what I learned is that a surgeon can lose the control when they do live surgery. And the most important is if they lose control, they have to stop, relax a little bit, and restart the surgery. I saw big surgeons solving themselves complication with some, few minutes of relaxing before continuing. So surgery is something that has to be done, let me say, in a smooth way. I mean, relax, controlling what you do, and if the surgeon loses his own control, is having complication. And so the best is, I happened several times to me to stop a surgery, to spend 5 minutes relaxing and going back to the eye and solving the case. I mean, one of
Mhm.
the most important steps that I learned during live surgery. But I also learned a lot of, techniques, a lot of IOL implantation, a lot of, uh, how to use the viscoelastic, how to do the perfect rexis, how to do, the removal of the cortex. I invented the bimanual IA because I have the ability to use the two hands, and I was unable to remove the cortex under the incision. So one day I
Mhm.
decided, why should I do that? I have to change technique. So I started on 92 live surgery during video cataract. I showed the first time the bimanual IA technique,
Yeah.
and you know there is a lot to learn every time. What I believe, what I strongly believe, that you never stop learning.
Right.
If you wanna be able to do your profession with happiness, with good results, with your having good patient, you have to continue learning and studying and improving your procedure. Never stop. I'm 80 and I'm still continuing studying. That's the lesson that I will give to the young doctor.
I think that's so important. And I love your idea. Keep learning. And then also keep asking yourself, how can I make the procedure better? Like when you invented bimanual IA, you asked yourself, there has to be a better way to get subincisional cortex. So you
Yeah,
came up with the idea of bimanual IA. But to always question, how can you make the surgery better?
yeah, that's having our patient happy is our object, our aim, our intention, our desire, our and so this can be obtained only if you improve your procedure, if you use the most updated technique, if you use the most advanced instruments, if you use the most new products, IOL, viscoelastic, or anesthetics, or whenever you want. I mean, I found very interesting, for example, the use of the devices, the electronic device, to put the toric IOS in the right axis. This is very important, I think, is because we have so many toric patients, astigmatic patients, and this way is really helping a lot. Um,
It's a lot more precise. So I think we are moving towards what we call the digital operating room, where you have the preoperative scans done in your clinic, which show the steep axis, flat axis, data sent over to the microscope. So as you operate, you can see where it is. But I think it's going to go even a step further. I think if you think, you could even have it recognize the patient's vessels to make sure you're operating on the correct patient. You could even have it do intraoperative measurements to see how it's going. So I think we're going to definitely get more and more digital operating room stuff.
And I must say that the new iOS, in fact, they don't rotate so much. I mean, they stay there in position if you remove well the viscoelastic on the back of the IOL, and if you clean the anterior segment of the surgery, they stay on the axis. I saw also that very often with the phakic IOL, implanting many phakic IOL. And when you position properly the axis, they stay there. They don't move. They don't rotate. Very rarely.
Yeah, I think I agree. For certainly toric lenses in the bag, the incidence of malrotation is much less than 1%. It's very rare. There's obviously very stable procedure here. Well, wow, you've had an amazing run here, and I'm looking forward always to seeing what you do next. I think with you having 40 years or more than 40 years of meetings, you need to have a good online library. So I can go back to like 1993 and see what was being done. You can have a beautiful online library with this. You have so much
Yeah.
material.
And the idea is, I don't know if I will be able to realize, made a non-profit company for the preservation of historical videos. If I find a supporter, a company who can support the project, with Bob Osher, we have a large collection of historical
Right.
videos, and it will be very nice if we can obtain support for a similar project.
Right. It'd be great to have all of OSHA's library online. Of course, your whole library online. I think from a historical perspective, there's a lot we can learn to see how
And
things
if you
evolve.
And after you can add yours. So with the three of us, we have everything.
just about. Oh, it's a fun. Well, like you, I love ophthalmology, and
How
to
many
me, it's
videos do
fun
you
to
have
make
in
the
your
videos.
collection now? How many videos do you have in your collection?
More than 2,000, 2,060 something.
I have
I just
more,
do a
but
new one every
I
day.
have more, but you are reaching me because you are young. I'm old.
Well, I do a new one every day. No matter what, every single day there's a new video. So, and now we're doing our podcast, which I'm so honored to have you on this podcast because you've always been an idol of mine. I've learned so much from you over the years. I've always just thought like, wow, I want to be like Lucio. I've learned so much from you.
That's very nice, very kind from you. Thank you.
So yeah, please send me those links. I'll put them down below so all our viewers, all listeners can go to all those websites and see about your meeting, about your online library of videos. And then also, please send me a video of any surgery you want to feature. We can feature on Cataract Coach the day after your podcast. Any imaging video.
My staff is very, very busy. We had a lot of surgery, a lot of consultation. We don't find
Right.
time. But it's a couple of years that I say I have to send some videos to Cataract Coach to my friend. And I every week or two I say I have to send something, but I promise you,
You can just
I
send
will.
one video. You don't have to edit it. I'll edit it for you. I'll do the voiceover. Just send the raw video.
Okay,
Anything you
I
find
promise.
interesting.
Okay.
All right, Lucio. I want to say again, thank you for doing my podcast. I'm very honored. I think our audience will really enjoy learning about your incredible history and all the things you've done in ophthalmology.
It was my pleasure. Thank you very much for the invitation. I really appreciate it very much. I hope to see you in Boston maybe for a meeting.
I'll be there for sure.
Okay. Thank you again. Have a nice time and Happy New Year.
Thank you, Lucio. Ciao.
Ciao.
I want to thank you for enjoying this podcast with me. I trust that you found it entertaining and that you learned a lot. And if you're ever in Italy, in Milan, please check out the Video Cataracta Refractiva meeting. And again, thank you to Haro for sponsoring this podcast.